welcome everyone. I'll give everyone a moment to kind of settle in, and if you are available, it'd be great to see you, with your screen. But we'll give everyone a moment just to kind of get situated. Definitely see some familiar faces. So we're gonna kick this off. I wanted to introduce two special guests for the clinical rehab questions panel. I'll have them just introduce themselves. We have a bunch of questions that were submitted by all of you, and these are also pretty interactive, so you can drop in the chat if you have questions as well, or if something comes up, drop something in the chat at the same time to kind of facilitate a concept, and we'll try to get to those comments too. Without further ado, I'll make some introductions. Our goal is to, it's 5:30 Pacific time or 5:37. These run about an hour, and we'll save just a little bit of time at the end for anyone who wants to stay for a few minutes. Split you off in one-on-one just to meet a new person in the climbing community, say hi, and see how things are going. But without further ado, I'll introduce. We'll start with Nina Tappin. Nina, do you want to kind of introduce yourself and to everybody?
Sure. I'm Nina, and I've been practicing as a physio for 20 years now. Started out in orthopedics, got a little bit into occupational therapy, and then decided that I was kind of more interested in the sports rehab side of things, and got into climbing around the same time, and just started treating a lot of climbers. And then, got interested got a lot of climbing injuries myself. So then I just started researching things and found out that there wasn't a lot of stuff out there research wise, or even, physios that knew much about climbing at all. So I started to kind of dive into, researching it myself and kind of putting things out there in the UK when I was living in the UK. Studied in Canada, but lived in the UK for 15 years. And then did a sports certification in the UK, and just started applying all that kind of sports knowledge to climbing injuries. And here I am now back in Canada in Squamish, BC, and I'm pretty much solely treating climbers now out of a home practice.
Yeah, not a bad place to be, right by. How long does it take to get to the Chief?
To the Chief, 10-minute drive. And then to check to the climbing, near Whistler, 10, 15, 20 minutes. That's perfect. So, yeah, it's great.
Jason Hooper, do you want to introduce yourself?
Yeah, so my name is Jason Hooper, and I do not live 10 minutes away from a really nice crag, but rather 2 hours to Black Mountain. I'm in San Diego, California, and I've been a physical therapist since 2015. I'm a board certified sports and orthopedic clinical specialist, and kind of got into the climbing scene at the same time I was studying for my boards. And then, my friends around me were getting injured and no one was there to help them. And eventually one day my friend Emil said, hey, we should make videos about climbing and rehab. So we started Hooper's Beta YouTube channel, and have been transitioning into treating more and more climbers as my sole focus. Have developed a rock climbing rehab program at UCSD. So working with certified hand therapists there, so post-injury, post-surgery, transitioning back into rock climbing, as well as developing my own private work with climbers. And it's, we're looking forward to more and more climbing and expanding that into treating more climbers.
Nice, thank you, Jason. And I'm Jared Vagey. I'm a physiotherapist, and I think I got my degree in 2009, orthopedic clinical specialist, and run a webpage called theclimbingdoctor.com. And I see a lot of rock climbers, and it's a passion of mine, and I've been doing it for a while. And really tonight, the goal is bringing everyone together. This community, we have physiotherapy students, we have people in the Rock Rehab community, we have people that saw the link and signed on. And really what we want to do today is just have a little fun, be light, bounce around some clinical concepts. I'm going to be learning things as we go, and I'm sure everyone else will. And we have the questions that everyone submitted. So I think without further ado, we're just going to go right through the questions. There are different body regions, starting at the fingers, wrist, elbow, questions about special tests, some non-clinical questions about like just practicing as a physio or physiotherapist that treats climbers. So we'll go through and share some of our knowledge, and feel free to drop stuff in the chat as we go if things come up. So let's just start. I mean, why not start with fingers? Because that's a large percentage of climbing injuries. And probably there's a question on chronic PIP joint stiffness. So Synovitis. And the question is, how do you rehab, and what do you give regarding climbing, rest, and load? So Jason or Nina, did either of you want to kind of kick that off for capsulitis, synovitis of the PIP joint?
Yeah, I see a lot of that. Yes, I don't know if Jason, if you wanted to start or.
By all means.
Yeah, I'd say it's fairly common. And the middle finger I find is the most common. And I kind of have a theory that the middle finger will get used a lot, right? Whether you're like middle 2, 3, or 4. And often if you're like open, the middle finger has to do this, like Beastmaker calls it beaking, where, it'll still be in kind of a half crimp a lot of the time. And so, yeah, so the middle pip joint, I'd say is the most common. And I'm big into passive mobility. So, like doing extension mobs, flexion, where you squash, and passive hook, where you extend that MCP and flex the others, and doing it in warm water, contrast baths, and some massage, regular massage. And there's a couple of videos that patients have found that I find useful. The Japanese, I forget her name, Aikio, the Japanese Olympian. She has a nice YouTube video on this massage. She does a lot of acupressure points to bring blood, and does some of these kind of passive mobility things. I think that's useful. And, using the wave tool and scraping and just good warming up, weighted tendon glides. So just doing kind of tendon glides alone, I think, is not good enough. Actually, it's good to do weighted, versions of kind of like finger curls before climbing. After, before and after, it's got to be light intensity. But sometimes if you want to offload on the fingerboard and focus more on dynamic strength, then you could load that up more. And then this other climbing physio in the UK, I saw him do this kind of traction technique that I really like for the pip joint, where you keep the wrist and hand straight, and you like pinch the proximal phalanx and kind of, press up as you pull down, and do like a little traction and twist. People seem to like that. But when it gets really chronic, it can be annoying. And I've had a few Asian patients that have said to me that they've seen doctors and hand surgeons, and I've had this a few times now, where Asian population supposedly get more finger chronic arthritic, early arthritis kind of signs. And I have to say now, working out west here for the last 5 years, I'd say I have a big percentage of Asian population where there's a chronic kind of capsulitis thing happening. So there might be something also genetic. I've not looked it up research-wise. This is all just anecdotal, but it's kind of interesting. And I've seen, a lot of cysts, and sometimes they get so big that we've had surgery. And often I'll just say, if you see a cyst, forget about it, just ignore it. And that motion is lotion. And in general, you know, you just want to mobilize those joints as best as you can, and stay on top of it. It's fairly easy to do. So yeah, so I kind of talk about finger care, mobility work, and then really being strict on warm-ups and healthy tendon loading. And that's kind of how I go about it mostly, I'd say.
Jason, is there anything kind of to add, or, you know, kind of thoughts, different spins on things that you do to manage the condition?
Yeah, I think so one of the big things for me is actually looking for like educational gaps. So Nina kind of made a good point about the overloading to that third digit, because that is, you know, what I see most often too, is that PIP, that synovitis of that third digit. And not only oftentimes are people, when they're saying, even in the drag position, you know, still getting that slight crimp to it, but there's oftentimes just a bias towards those fingers, even when they're on a crimp with all four engaged. They may not actually be putting much weight through the index or the ring finger or the pinky finger. So they're creating a lot of bias towards one joint. The other big educational gap, and I always kind of feel like a little bit of a jerk, like I'm, you know, when I ask this to people, but I tell them, I say, show me a half crimp position. And you'll be, you know, surprised how often they go into a full crimp. And so it turns out like the entirety of their climbing career, they've been like, I don't ever full crimp. I've been told it was bad. And it turns out they've been full crimping their entire time. You know, and in that position, they're going to get more aggravation. They're closing down the joint space. They're having that hyperflexion of the joint compared to other positions. So identifying those educational gaps and teaching, you know, that the force distribution and those appropriate hand positions is a big gap to close in regard to awareness with their climbing. And then when it comes to like having them go back through their training, you know, and in rehab, I loved a lot of those points about like creating more space, looking at that intrinsic hand tightness versus the joint tightness that's been created. And then loading more, you know, in an open hand position for a bit until they can kind of comfortably go back into those half crimp positions without creating irritation.
Yeah, and I'll kind of jump on to kind of second a few things. Is it's interesting because when someone's in a half crimp or a full crimp, they have maximal flexion, but when you're crimping down, you actually have an axial force as well, compressing the joint because of the vector of gravity when you're climbing. And so those are really challenging. And there's like intrinsic factors we can change and extrinsic factors we can change and intrinsic ones we can't. So like finger anthropometrics, can't really change those, right? If somebody has, you know, really short pointer finger and ring finger relative to their middle finger, you know, we can't really change that. But when they're crimping, you know, just as Nina was talking about, they're going to have to, you know, change and chisel down that position of that middle finger a little bit on the open hand. And then similar, you know, when they're in crimping positions. I think joint mobilizations, I've had success with those if in the clinic compression brings on symptoms and distraction relieves symptoms. I've had some success with joint mobilizations with targeting the, you know, the PIP or DIP joints and using that more palliative as a way to just allow them to get a little bit more range before they go through any of their range of motion. So it's a really tricky condition. And I mean, can be quite chronic and it's a cycle. Like you see climbers, they've been climbing for 10, 15 years and they may have synovitis that kind of knocks them down in this cycle. And I think a big thing is talking about managing and really the expectations. Your finger joint is not going to go back to how it looked before, you know, if you're in the chronic condition, and it's really about managing your range of motion and your load.
Yeah. And another thing that I've kind of come across, like from myself, but also I've had other climbers kind of get their fingers x-rayed, because that's the first thing that they do here before you get any ultrasound scans or MRIs. And sometimes, and I actually trapped my finger in a car door, long story, fighting with my toddler at the time or whatever, my 4-year-old. And then and it was really kind of a bad injury and I yanked my finger out. Anyway, long story, all to say that I got an x-ray and it showed a little avulsion fracture. And they said, oh, that looks, whereas I had it trapped here. And so I thought, oh, that's interesting. And they said, it could be old. And I thought, okay, so that's my pip joint that I did do a collateral ligament strain on a boulder problem once, and it does like flare up. Actually, it's this finger. And from time to time, I'll get like a little synovitis. And then I, speaking to more climbers about it, and they're like, oh yeah, I've had that. I've had, like little chips that, they've said that looks like little avulsion things. So I think, lots of wear and tear, you could get these little mini avulsion, especially let's say climbers that have climbed a lot in their adolescence and could potentially have little growth plates, old slight injuries that then later on, can present as kind of these chronic synovitis things or little flare-ups,
I'll just jump. Oh, sorry. I'll just jump on one quick thing on that topic. This is kind of what it looks like. This is a research study by Schofield and colleagues, and you can get some extensor hood irritation, as you can see with some of the images on top. So it's nice in Canada. You can, first practice is quickly imaging to rule things out. It's in the States. It's, I think maybe Jason, I speak to, it's a little bit harder, that process in the medical system. Actually, Jason, maybe easier for you since you're, you kind of have that proximity, but.
It depends on the physician, some of them are great with that, others not so much. But I would also add on it too, as you guys can kind of chime in on this, but how often, and this isn't always the case, but how many more times do we see like synovitis related to climbers who say they're climbing, like 2 or 3 times a week, managing their volume quite well, versus ones that, like, yeah, well, I just was on a 7-day climbing trip and then I was really excited. So then I climbed for I took a day off and I climbed for like 4 more days. And then I took another day off, but now my knuckles are hurting. So, talking to people about, I hate just saying overuse, but about the volume of their training and how much they're doing and how much they're doing with these different positions can be important as well with these issues. So it's almost one, like I agree with Jerry, where it's very hard to manage in some cases, but a lot of it to me is the educational piece, is the educational gaps, the overuse, the hand positions. And then I always like to emphasize that P word that no one likes, patience, because you can, like, the tissue can calm down, you can get back into the full strength with this. You just have to be patient.
I thought your P word was going to be pull harder, but I guess that's 2 words, right?
I have this, it's kind of rubbed out because I put it, I kind of got it rubbed, but this is my little, it says practice patience and your lock-offs. So I have this up in my clinic room here as a reminder for me, as well as all my patients, to have patience.
Ooh, nice play on words.
My motto is that the body is very adaptable and the brain is very stubborn.
Yeah, awesome.
So let's move on, still the fingers, but let's do a question about pulley protection splints. So someone had asked, and this is a good topic, a good question, and even to stem a little bit of debate, but a climber injures their pulley, and they usually on ultrasound image may have increased bone tendon distance, greater than 2 millimeters typically, and what that will show or indicate indirectly is that there's a pulley rupture. And so it's common practice to put a splint over the finger to improve that bone tendon distance. If a good splint is fitted, typically you won't have more than 1 millimeter of that bone tendon distance occurring. When you're crimping, you'll sometimes go up to 2. You can't full crimp. You can only kind of go down just a little bit if you have a tight one made. But a big question is, how long should climbers wear them for? Meaning, like, how many weeks? How long during the day should climbers wear them for? 23 hours a day, just during functional activities, etc. Do we know the answer to this? Or are we just guessing? And yeah, what do you kind of do in your clinical practice? So I don't know if either of you want to jump on that, but there may not be a right or wrong answer at this stage, but I'm hoping in the future we'll have a little bit more insight. But who wants to jump in on that one?
Yeah, I mean, do you want to go, Jason? I mean,
yeah, sure. Yeah, I mean, again, of course, it absolutely depends on the severity of injury, right? So if we're looking at just a minor, like a grade 1 strain, not too big of an issue, I may, if they ask about it or are curious about taping, encourage some H taping or protective taping. When you get more in like the grade 2, it's still kind of a gray area for me if I think they need an actual splint. But if there is ever like a rupture of any of the ligaments, the pulleys, then I'm absolutely gonna to recommend that. If they have to be immobilized for a bit, the bracing would kind of start after that. And I usually would recommend in the beginning, maybe more with their like day-to-day use, just to protect it. And then after maybe a couple more weeks, transitioned more to just using the brace with activities or with loading. And then as they progress, trying to get them in more to a just like kind of a controlled scenario where they can load their tissue again with just maybe taping, if we're further enough out. But really, like, I'm not on the end of encouraging like bracing for super long. Of course, if it's surgical, then that needs to be said. But the one thing I like to always consider with my patient is going to be the patient themselves. How aggressive do I think they are versus how much fear do I think they have with their return to climbing? If I have a patient who's going to be particularly aggressive, wants to get back to their project in like 4 weeks, I'm probably going to recommend that brace maybe for a little bit longer, only to kind of slow their roll a little bit so they can have good healing. And as Jared kind of pointed out, it'll stop them from going into some of those positions so they don't just set themselves back so abruptly. Whereas if I have a patient who seems like they're going to be terrified of ever climbing without the brace, we're still going to recommend it at an appropriate time to start transitioning to the taping. But I don't want them to become dependent indefinitely on that support system, because then I also find those patients become more kind of chronic pain related with it and or hypersensitive in those positions. And then, you hear those patients who it's like 1 year, 1.5 years later, they're like, yeah, I still have pain in that pulley in that position. It's like, okay, is that because, your rate of force development is bad and it's, enabling that neurological protection response or whatnot? So there is, I do follow like some timelines with it, but I also pay attention to the specific patient and what I think they're going to need based on what they're telling me.
Yeah, I think that's a really good point to kind of take into consideration. Yeah, like, like fear avoidance or someone who's going to push themselves too hard. And I think that's a really trendy thing in physio right now and a really necessary thing, and something to consider for sure when you're talking immobilization. I work with hand therapists, and luckily recently there's an occupational therapist that I used to climb with, which is really nice because before the hand therapists here, we're all non-climbers. And it was okay working with them, but it's just more fun now to work with a climbing friend. And so her and I'm going to share my screen because these splints, I find they're really easy. They're not too expensive. And I think they're trending. And Jared, you showed how to make one yourself.
Oh yeah, I'll drop that link in. Do you have,
Yeah.
go ahead, share your screen with what you have.
Yeah. Can you see my screen?
No, redo it. So cancel it out and then reshare it, if that's possible.
Okay. So hang on, share.
There you go.
Now, okay. So this is like a splint that she made. This was for the not A2, but like kind of A3. And it's just tape, like, so it's just thermoplastic, and you wrap it around with the little gap so you don't fully compress. And then the other one, oh, nope, hang on. How can I move this way? It's a stretch. So the next video must be here. Yeah, so that's more A2. And just, you can like wear it. You can just slip it on. You don't have to worry about your tape job. I think they're really good, for kind of bad pulleys, or painful pulleys, kind of, like a chronic. So I've used this on a chronic pulley that just was struggling to kind of heal. It was showing kind of like a fusion, and yeah, it worked well. Should
Nice.
I unstop?
Yeah,
share?
do the
Stop
unshare.
share. Yeah. Okay.
Yeah, it's interesting. I'll drop a link in. You know, I used to fabricate these quite a bit. And there's a video, we just made like a free video for people to just show, you know, physiotherapists, physios, how to just like makeshift, you know, with
Yeah, so we used that video. We were there together at the clinic, and we were, yeah, and so we kind of copied your stuff here.
So it's kind of a fun video. It, you know, it does take a little bit of time. I mean, there are some now that are, you know, they're getting commercialized now, so you can buy them in different sizes. They're being 3D printed. We're playing around with a bunch of 3D printing as well for them.
Oh, cool.
And yeah, in a matter of probably like 1 to 2 years, my thoughts are they're going to be really readily available for climbers, but there's going to be a bunch of different styles.
Awesome.
And so one thing will be interesting, I think, in the future would be doing a little bit of research on, you know, basically, you know, bone tendon distance and comfort, because in the end, my biggest barrier is compliance. And, you know, there's some great studies like Schweizer and Schneeberger did a really nice study. I'll just share the screen. You know, many of you are probably familiar with this. They had 47 people wear these pulley protection splints, and they had them wear them like 23 hours out of the day, which is a really long time. And they had them wear them for up to 2 months, and they had rather good results with them. You know, out of the 47, I think like 30 or 43 of them, they had a questionnaire as they got back to their, you know, kind of pre-climbing level. My challenge is compliance though. And it's really tough. You know, they're not that comfortable. They're not that comfortable to climb and load on. And I'm battling whether to recommend them in mostly for grade 2, 3, 4. I rarely recommend them for grade 1, although Luder had a paper that came out that did recommend them in grade 1. But my challenge is basically getting climbers to keep them on. And I think that's going to come down to comfort. And then really figuring out, do they need to be on that long? Can they just be on when you're loading the finger during your exercises, or maybe going through early stage range of motion? Do they really need, you know, that kind of 6 to 8 weeks? And so I do a lot of compromises, as probably Jason had alluded to as well.
Yeah, fair. What, you're going to give us that link to that article?
Oh yeah, I'll drop in. I'll put it in the notes, I think. Let me just put, yeah, link to the article. Really nice article. I think what's going to be the evolution of that is going to be comparing wearing pulley protection splints and not wearing them, and then going through a typical load protocol, because it's possible those climbers may have gotten better in time without the splints on. So yeah, I think there's a lot of possibilities for future research. And maybe I could pull up, there's a Luder article somewhere, but that one, if people are interested in, oh, here it is. All right, let me share this screen. This is a really nice article that kind of lays out, this was recent, I think it was last year, and it kind of lays out, this is best practice, meaning this is level 5 evidence of what someone you know, feels is appropriate based on clinical practice. But they're saying here is functional therapy with the splint, 2 to 4 weeks, 6 weeks for grade 2, and then 6 to 8 for grade 3. So there's resources, there's parameters. I think all of us as clinicians, we kind of handle this on a case-by-case basis and use that information to inform us. Anything else on those topics before we kind of move on, different body regions? I think related to that, Aaron dropped in a question, is there any reason you'll make a referral for grade 2, 3 pulley sprains to a doc? In the early stages, I was referring them to docs to create that relationship before I was, you know, ultrasounding fingers and kind of getting that data. At this stage, unless they're getting surgery, I'm rarely, I mean, it's rarely a priority. And surgery is now in 4A, 4B. So 4B are your surgical options, based on that Luter study. So now it's not even, grade 1, 2, 3, 4. It's grade 1, 2, 3, 4A, and then 4B. So I rarely do that, but I'm more outside of a medical system. I don't know, Nina, Jason, kind of 2, 3, your kind of process with your docs.
I'm in the system, and I still don't ever, unless I needed to get something else done, then, or had a different suspicion, then no, I don't for a 2 or a 3.
Yeah, I would only refer for, 3 or a 4, but I like to refer for scans. So occasionally, I like to get an MRI or an ultrasound scan.
Cool. All right, let's move on to the wrist. This is a question. Best intervention practice for a TFCC injury, symptomatic with compression, and I'm assuming asymptomatic with distraction. So like a TFCC load test brings on symptoms. So maybe, favorite stuff to do, clinical tools. Go for it, either one.
Yeah, do you want to go first, Jason? I don't know, whatever.
Yeah, it's fine. That's funny. I was actually reading that as in like if they're symptomatic with compression or if it's with distraction. So
either one. Let's go for it.
Yeah,
Let's do one for each.
Yeah. So I mean, honestly, for me, if they're having pain either way, like the first and foremost thing I want to check based on like the mechanism of injuries, if there's a hypo or hypermobility of the wrist, whether that be the drudge, the distal radius ulnar joint, or the proximal carpal row. I had because you talk about compression, I actually recently had a patient who had pain with compression and like a pretty decent click with ulnar deviation. And, first assessing just the proximal row on the distal radius ulnar joint, and they felt hypomobile. Okay, so thinking perhaps there's just a joint hypermobility here, and that's causing a little bit of, compression. Maybe they have there's the ulnar styloid bone is a little bit extended. Maybe they need an X-ray for that. But the reality is they had kind of a congenital like lunotriquetral ligament injury / rupture. So their triquetrum was actually in an extended position. And so they had that proximal carpal row instability. So they were getting this significant click and compression with ulnar deviation, but due to the instability in the proximal carpal row. So it's really important. That's one of the first things I do is look for any instabilities, because that can cause issues one way or the other. Because if they have pain with distraction, it could be a hypermobility at one of those joints as well. If they do have more pain with that distraction, or if it's, loading, then I'm looking at, is it a stability issue? Looking at the surrounding muscles and seeing if there's weakness in certain positions. I always like to ask if someone has like a TFCC injury or wrist pain, I always ask what their opinion or thought is on slopers. Because people with wrist pain tend not to like slopers as much, or the opposite. They love them so much and that's all they ever do, right? But people I find that who tend to have or don't like slopers as much also have they have no cross training for the wrist stabilizers. They generally have some instability in the wrist. And so whenever they find themselves coming across those problems, they overload the tissue, they create this ulnar-sided wrist pain, and that's when they come in and present with some pain in that TFCC area. I know I have a lot more we could talk about on that, but I'd like to just kind of start it, get the conversation going.
And Jason, do you have any links or any materials on that? I think don't you have a video on TFCC?
Yeah, we have a couple of videos on TFCC injuries and stability-based exercises as well. I don't have that up right in front of me right now, but
people can check that out.
Yeah, we'll check that out.
Yeah,
I would like to just add that the wrist widget can be quite helpful, even if it's stiffness or cartilage, or because the TFCC, from my understanding and research, is so like before, I just always thought it was the cartilage in between, like the little meniscus in your wrist here. But actually, you know, the wrist and hand therapists call any pain on the outer side to be TFCC pain or diagnosis. And actually the wrist widget, I think, is helpful. That was a hand therapist that introduced me to that a long time ago, and climbers get along with it, and they're compliant because it's just easy to whack it on and it doesn't disrupt motion. I think it's something to consider, and it's cheap. You can just buy it and try it. And if it doesn't work, then who cares? And you could have one in the clinic and just try it on and try different strength tests, or, you know, grip, you know, handheld dynamometer even, or the you know, extension compression testing. But yeah, you know, I think around the wrist, it's tricky. You know, oftentimes there is, you know, it's some instabilities, and at the climbing symposium where Jared and I got to meet in person, I don't know if you remember Jared, but the wrist surgeon from Toronto really made an impression on me, because he presented this concept again about adolescent and adolescent, and actually anytime little wrist injuries that happen, skateboarding, snowboarding, skiing, that were kind of, you know, people forget about, but then later on can cause problems like little instabilities that, you know, little stretched dorsoscaphoid ligament that they never really knew about and brushed it off because they were young. But now, you know, either having a manual job that's really wrist intensive, or something like climbing, and, you know, like crack climbing and twisting in here all the time, you know, can present itself as a painful wrist. So I thought that was really neat just to consider, and like questions that you would ask in your subjective. You know, and then also that, you know, you could have this like ulnar variance issue where if you had a fracture in the radius, but you know, the ulnar grows longer, the radius shorter, or vice versa, you know, that can kind of be a problem later on. So yeah, lots to consider with the wrist. The wrist is quite complicated. And then, you know, and always kind of working up the chain, right? So if your shoulder, girdle, and core are weak, you know, that you have to always kind of look at that as well. But rehab wise, if you're kind of like confused and you don't know where to go, I think one of the safest things to start with wrists is just wrist neutral isometric loading. So I'd say it's very successful for me. And it's something that you can start with day one, even if you're not quite sure what's going on. And you know, I've got some stuff on Instagram I could share if I can do this quickly. You know, it's basically isometric holds where, you know, actually I'm just going to do it on my phone if that's okay. You know, so you would like load up ulnar side, show them where the neutral kind of wrist position is, because some people think this is neutral, you know, that's their centered position. So kind of showing them what centered is, and then just training quite heavy isometrically, you know, so something like this. You know, and you could do it with a saucepan with water. So hang on, so you kind of like place it, engage, find your neutral, and then load. And obviously your ulnar deviators are a little bit stronger because there's more of them. So you would choke up on the lever arm for the radial deviators. And, you know, sometimes you've got an imbalance, like your radial deviators are really weak compared to your ulnar. And so that's something quick. So yeah, so, you know, if you're stumped, I like to go with those isometric, you know, so isometric neutral wrist extension holds. You know, I've even done it for, she's not a climber, but, you know, like we even just did, you know, find wrist neutral and then just, you know, hold the weight 5 seconds times 5. And yeah, I'd say I get good success with that.
I wouldn't mind adding on to that too, as mentioning the point of, you know, sometimes it's an imbalance with the shoulders as well. I love when I can create the opportunity to get a 2-for-1. So I actually have like a little example. Some of you might know this exercise. I'm going to share here. Let's see if I can get the right one. Perfect. So if I can get this up. So we might be familiar with this exercise, but the whole purpose is actually placing the resistance band across the hand. I'm now actually staying in a neutral position at the wrist. I'm
Great.
getting that external rotation of the shoulders, the serratus anterior, but I'm also getting wrist extension. So I'm playing with a shoulder exercise, but getting wrist stability from that.
Awesome.
And I also even I don't do like a ton of prescribed shoulder, just internal rotation, but very similar to what Nina was saying, a very small range pronation, just going out to 45 degrees and back up. But I keep my arm just off of the body. And at this 45-degree angle, you then also get some static internal rotation of the shoulder. So, another little 2-for-1 you can work on. And I like to do that with a lot of my my wrist exercises, incorporate the shoulder into it. So you're working that entire kinetic chain and making it more functional for the athlete.
And I think to layer on, what Nina and Jason has said, I mean, the risk comes down to strength and sensory motor control. And really by incorporating the whole body, you get that sensory motor control. And if you think about it, what do we do with an unstable shoulder? If someone has an unstable shoulder, well, we'll train some perturbations as well, or something to, create the quick muscle movement. So kind of another thing to piggyback on that. Could be, multi-direction. These are kind of fun, is playing around with keeping the wrist stable while providing some perturbations. And you're now getting, obviously the shoulder, the wrist as well. And you can bias those if you need, with ulnar deviation. Having a little more fun with it. So I trad climb quite a bit. So all these weird trads things. So taking a crack block and shamming your head in the crack and providing some perturbations on each end as well. And, the more we can start taking these, making them functional in the climbing, one, they become fun. And the other thing is we can hope to get some of that sensory motor control to stabilize the wrist itself. I think we're going to have time for one more clinical question. And then we had some questions about just general practice questions. And since we had some of those, maybe we'll do one of those and then kind of wrap things up. This one was interesting. It's what are your favorite climbing specific special tests to perform? I thought that was kind of an interesting one. I don't know if either of you want to jump on this. If you want me to, maybe I'll jump on this one first, because I have a lot of fun with let's see. I have a lot of fun with dynamometry. And so, you could dynamometer the wrist extensors or the wrist flexors, or you can play around. And, what I'll do is I'll use some of the portable hangboards, place that in the climber's hand. And this is just a compression-based dynamometer. And, I could take a lashing strap, secure that to the ground and, put my hands over there. And, they can, if they need, they can stabilize either at their proximal lower arm or distally at the wrist, with their other hand. But you can get a nice dynamometry assessment comparing wrist flexor, wrist extensors. And so I love using some of the different types of portable hangboards, using some, either it's a tension-based or compression-based dynamometer, and then getting some values that are better than just if I were to manually muscle test wrist flexors or extensors. I still manual muscle test. I still screen, whether it's for pain provocation or looking at movement patterns. But I think some of the dynamometry is I don't know. I enjoy it, and it's quick to set up. So that's a fun little.
And what's that unit? Because there's a couple of the pressure dynamometers that I find quite expensive, although I did buy Tyler Nelson's Exergio, so I use that a lot, which was expensive. But what's the press unit? Because that looks different. I've not seen that one.
Yeah, I mean, these are K-Force dynamometers. These don't run cheap. These run about, I think, $1,200, and then I think $100 shipping. The app is so clean, though. It's from, they just have I use it because of a clean app interface. But you can get crane scales for $45, and there's been comparative research studies, crane scale versus force plates. And crane scales, if you do a slow buildup isometric 5-second fixed position, they do have a acceptable reliability.
Yeah.
And then you have all, I mean, Tindex, like climbers use Tindex a lot. I don't know, Jason, do you have any other components, or Nina, do you have special ones that you like using?
Yeah, so so I've got Exergio's, G strength, and I do a lot of finger testing with that. Like I can show a little demo. And there's a guy, a Quebecer guy here, who I think I'm just going to buy it because I can use it for the pressure. His name's Entralpi, and it's about $200.
Oh yeah, those are great. Those are nice.
Yeah.
For non-fixated hangboard testing. Those are really nice. Yeah.
Yeah. So you can do the feet on the floor kind of hangboard thing, which is practical for people. But also I was thinking you could stand on it and do your shoulder manual muscle testing, and that could be quite interesting to do.
Yeah. Yeah. I mean, and it has rate of force development as a clean app interface. Felix is a guy,
Felix.
He's great. He's such a good guy. But that's a really nice.
Buy one of those. But yeah, so, and then, but if you don't have any equipment, like I love lock offs, so bar closed grip lock offs. So just like getting people to, look at their shoulder posture, wide lock offs, shoulder width lock offs, chin up lock offs, you can tell a lot from a lock off. Wrist position, hangboarding, finger blocks. I think, just making it specific to what climbers use to train with. You've got to assess them really with that sort of stuff. But if people don't know what the Exergio is or the Tindig stuff, so this is like an example here. So you can do it overhead. It's the little green thing up there. That's been really useful to my practice. And actually I've used it for my ankle because I had ankle surgery. So I tested my everters and inverters. Nope, my battery's going to die. So that's the little machine anyway, but yeah, that was expensive, but I use it a lot. So it was a good investment. But there's all kinds of things, like in Europe, there's Climbro. That's another kind of assessment tool.
Yeah, I have one of those. That's a direct assessment. I mean, they're quite expensive. It's a instrumented hangboard. But the nice thing with those is they're direct assessment of pressure. So you have a wooden hangboard with a plate inside it, and then on top of it is the top connection, and that one's app-based as well. I think that's phenomenal for research. The price point, it's heavy, but the price point may be a little bit higher kind of clinically, but that one is quite nice for like exact values.
Yeah, and also just handheld dynamometer. So I've just got a cheap one that's reliable, and that's super useful, because and I discuss with climbers about fatigue, and you always have to compare sides because grip strength is a measure of fatigue. And so people have to be aware that they might just be tired, and are they training always tired? And this, like what Jason was saying, like climbers overtrain. And so if they can see measurably that, wow, their injured hand, they kind of feeling better, their rehab is going, but they're still not matching even just their normal closed grip strength, is still quite way off the other side. That's an injury risk factor. So they can't, they've got to kind of check in on their volume and intensity. So having objective measures are, I think, really important for climbers. They need to see the numbers, and, because as soon as they kind of feel a little bit better, they think they're better.
And Jason, any kind of last thoughts on either dynamometry or any assessments or tools that you kind of use or utilize? Or
yeah, I mean, I also use the Exergo. One little thing I like to do is see differences between pulling from the ground, such as a no hang, but attached to an immobile object, because you're going to take some of the pull factor out of the equation. When pulling from above, you'll get, the shoulder girdle, you get the elbow, the fingers. If you're just letting the patient lean, they're going to get more core, but there's going to be less shoulder dependence. So you'll get a little more kind of finger-based results. So I find that kind of interesting. But since we kind of talked about tools and whatnot, I just wanted to talk about a couple other little kind of tests that you can do, so we don't just hammer that one point home. just like some neat comparisons I like too is looking at someone's narrow versus normal versus wide pull up, because you can see strength discrepancies there. You know, wide you're going to get a little more lat, narrow you're going to get a little more forearm. See if they're stronger in certain positions, or if you can highlight any like different scapula movements in those positions. I also like to actually look at tricep length with overhead testing. Like if you just look at someone's, hitting my fan there, measured shoulder flexion, and then, you know, you measure the degree and then you compare that with the degree during their like an FMS test, seeing how much change you get of that flexion of the shoulder. And if there's a difference side to side is an interesting, like easy test I like to look at for overall mobility, especially to see if I think they may in the future be prone to some ulnar nerve compression at the tricep. Because we know, you know, greater than 90 degrees of elbow flexion, we're going to get a little more pressure on the ulnar nerve. When we're at like our end range pulling, the tricep becomes more active in a push muscle, you get a little more compression. So I like to look at that, especially if they've had like elbow pain. And I obviously also then like to use like a pressure system. I actually have a BTE that I use. I might have to pull up a picture of that because I don't even think it has a name, but to measure external rotation versus internal rotation strength, especially at 90 degrees, very much so going to help me determine like shoulder stability and differences with that. So I love using objective data for that, but especially that internal versus external. I mean, I'll do it in neutral too, but really much more so at that 90 degrees of abduction to more emulate.
Yeah, can you show us the unit that you're using?
Yeah, let me see if I can get it.
And as Jason's pulling that up, I'll kind of just mention, I mean, we're talking all about all these different tools that can facilitate your practice, but I think we can all speak to this, to be a solid physiotherapist or physiotherapist treating climbers, you don't need any of them. You just need to be able to have your kind of foundational knowledge and be able, I think movement is key in understanding, and we don't need all these tools, but they're sometimes fun, sometimes helpful. I just want to kind of put that caveat in.
Yeah, you got to like get your foundations first before you need to depend on these expensive tools. This one is only made available due to working at UCSD, because this is a very expensive piece of equipment.
That's only 200 grand, I think.
Yeah,
Oh, God.
not bad at all. Not bad at all. But that one, like you can move the head around and then you basically attach different units to it to measure like rotational forces. So you can do external and internal quite easy with different attachments. But that's the BTE, the Primus RS, highly used by occupational therapists, but I utilize it for my climbers.
So I kind of want to end with just some kind of closing notes because we're about just a minute to 2 minutes left. And so we'll kind of keep these brief. But, you know, in your experience working with climbers, you know, if there was just something you can pass on, you know, from what you've learned, is there kind of one nugget that you can kind of share with everyone as a take-home nugget? And then what we'll do is we'll go ahead and end the recording. Everyone can kind of sign off if you need, or if you want to hang around and meet someone, we're going to do just 2 quick 5-minute breakouts with 2 people each. So you kind of meet a partner. But anyway, yeah, do either of you want to start on that? Closing words?
Take home nugget. I mean, yeah, it's yeah, I guess just really applying it to the climber and what they do, you know, and which is often not what you have in an average physio clinic, you know, so having, handheld dynamometer, a finger block to go over crimp positions, open hand positions, or to be able to pull statically. You don't have to have the force measure, because you can just do a static pulls. But yeah, I guess just relating it to being sports specific assessment and treatment.
And I'd say my biggest one is just experience. Kind of like Jared was saying a minute ago, like you don't need these fancy tools. There's, you know, the tools help, but experience and passion for what you're doing goes so far, because reading the research, doing the actual sport, being there to learn the positions and understanding how your athlete gets injured, then allows you to apply that to your anatomy, and you can you just help people so much easier when you know that the forces on certain muscles or the connective tissue changes based on these positions. So just getting out there, being passionate about it, and looking for that experience is going to help you treat your climbers, and it's worth it, because if you love this sport, then you'll love working with climbers. Well, I mean, most climbers, that is.
And I'd kind of say, when I started treating a lot of climbers, there weren't as many, medical providers doing it. And now, I mean, all of you showing up here and this whole community, I think this is in this early growing stage. It's so important for our sport. And that's part of why we're holding these, is to stay connected and to be collaborative, and to kind of get to know each other, because all of us climb and all of us are psyched on treating climbers, and we're spread throughout the country. And a lot of people who are watching this recording actually, kind of throughout the world in Europe, because this is not a good time frame for Europe. But either way, I think staying kind of collaborative. I've learned so much, even tonight. I learned a lot, from kind of Jason and Nina, and I think it's just kind of keeping the community together is an important part. So let's go ahead. That is all of our content. I'm going to stop the recording.